Good evening, everyone. My name is Doug Cushman. I am the president of the Case Management Society of New England. I'd like to welcome you all this evening. And I'd like to thank New Hampshire Orthopedic Center for providing our speaker and sponsoring our program this evening and bringing you this continuing education opportunity. Especially, I'd like to thank Karen Mackey, who is invaluable to New Hampshire Orthopedic Center, and she has been invaluable to Case Management Society of New England for many, many, many years, pretty much from its inception. Our speaker this evening is Dr. Gregory Sohikian. He is a fellowship-trained orthopedic surgeon, board certified by the American Board of Orthopedic Surgery, and only one of a few physicians in New Hampshire that also holds the board's certificate of added qualification in sports medicine. He subspecializes in shoulders and sports medicine. Magna cum laude graduate of Harvard University, Dr. Sohikian graduated medical school from Southwestern Medical School, University of Texas in Dallas. He interned at Mass General Hospital in Boston and did his residency at George Washington University Medical Center in Washington, D.C. He did his fellowship in sports medicine at Tahoe Fracture Clinic, South Lake Tahoe, California. We welcome Dr. Sohikian tonight. We're looking forward to his talk. Once again, I would ask you if you have questions to write them in the Q&A section, and we'll be happy to present those at the end of our session. Thank you very much.
Thanks, Doug. Appreciate it. And welcome, everyone. It's kind of strange not to be able to see people. I have no idea if I'm talking to one person or 20 people or nobody, but either way. So a little bit ironic that I'm talking about telehealth as we struggle through this. And so far, our technical difficulties seem to be relatively minimal. Obviously, COVID has sort of forced us to become a little bit more open to telehealth and also start to look at it a little bit differently in terms of being able to try to expand its role potentially. So first of all, introductory slide here, things I'm going to go through: definition of telehealth, a little bit of history on it, why obviously the COVID is our new motivation for engaging with this, what the limitations are with telehealth, what the pros and cons are, and then maybe a little bit about what we see as a possible for future role for telehealth going forward. Excuse me. So definition, technically telemedicine is the remote delivery of healthcare. Officially, and I don't know how long people spent trying to come up with this definition, the National Academy of, and that's actually telemedicine, I believe. It's the use of electronic information and communications technology to provide and support healthcare when distance separates the participants. And apparently there's a difference between telemedicine and telehealth. Telehealth is a broader term, meaning the delivery of all healthcare services and all aspects of clinical and non-clinical care delivery. Honestly, I see the two terms used interchangeably, and I certainly am not trying to work with one of them and not the other. There is what's called synchronous telehealth, which is basically when you are directly working with the patient or another provider, such as this lecture would be, where it's sort of live interaction or immediate interaction, and then asynchronous, which is communication through emails, voicemails, faxes, patient portals, where the timing is different, meaning one person's putting information in, and when that information is being looked at is a separate time frame. And so obviously there's a lag going back and forth. And in this, you could actually add US mail service as well as an asynchronous way of doing things. And we do still get lab reports in the mail, et cetera. So for what we're talking mainly about synchronous telehealth medicine in terms of real time and direct communication. So telemedicine started quite early in the late 1800s, just fairly shortly after they had telephones and started to be able to use electronic communication. The first EKG was transmitted via phone line. So this does date back a pretty long time. Things did not really start to change much until video transmissions became a possibility. And those started about 15 to 20 years ago. But initially were not sort of widely available. with personal computers. Skype was one of the first sort of more direct video chat opportunities, and that came out in about 2003, so 17 years ago. And then FaceTime, which has become sort of the most commonly used direct video conferencing or video communication, started in about 2010. So it's really only in the last 10 years that this is becoming more easily accessible, more commonplace, and the use of FaceTime also has exploded, obviously, with COVID, but people already had that technology more widely available in the last few years than it was 7 or 10 years ago. So what does it mean to us as healthcare providers, and in particular as providers for injured workers? First of all, it's direct communication, and it's the ability to evaluate the patients as well, but at a distance. And that's the difference, I think, between direct video capability and just being able to talk to somebody on the phone, is the ability to bring some of that physical exam aspect into the interaction, but also gives us a little bit more feedback in terms of visual cues, body habitus, body posture, all those more subtle things that can be sometimes helpful for us as well. You know, coming up to this year and prior to COVID, we were also already communicating very commonly with patients in terms of test results, updates for work comp case managers, work status updates, some of that synchronously, at least by phone, and some of it asynchronously through emails and other intermediaries. But the communication beyond just the patient visit has always been, I think, or for a long time, part of our delivery of healthcare, especially for work comp patients, where you have the involvement of case managers and adjusters as well. So obviously with COVID is our quote motivation here for increasing this. But there's been some changes with COVID that also enable us to do this more commonly. One is that in the past, and this is more so for private payers, but for all insurances, have been either reluctant to embrace telemedicine as a way to deliver health care. Mainly their reluctance is on the payment side of it. And as an example here, about at least 6 years ago, Anthem decided that they were going to do a trial program where they asked us to start to track, and they gave us a billing code to track phone discussions with patients. So these would be discussions about lab results, MRI results, possibly discussing options for treatment. And they started the process, and within about 3 months, so they agreed at the beginning, they gave us a specific code to utilize, and obviously we had to dictate the interactions, and they were going to pay a fee for each of these interactions at a lower rate than they would for an office visit, but they were going to pay a basic sum. Within 3 months of the initiation of their pilot program, they discontinued it. And when we asked them why, basically they said the cost. They had no clue how many non-official visits we had as physicians and providers with our patients in terms of phone calls and email messages and other interactions. And as soon as they started tracking it, they realized how much there was, and they realized that there was no way that they were going to then foot the bill for all of this. So as far as telemedicine is concerned, they are now required to, and this is for full visits, not just to review a lab study or something routine, to reimburse for that. The other part was changes in the, not just reimbursement, but the HIPAA regulations. Previously, it was fairly difficult to have a video conferencing system that met the regulations for HIPAA. And with COVID, they relaxed those regulations and allowed us to start to use more commonplace tools like GoTo and iPhone, FaceTime for these visits. So those two things, the money side plus the policy side, enabled us to have much more access to it and our patients to have much more access to it easily. So the next question is, does it really work? Is it as effective as an office visit, and can it work? And so to look at that, I think you need to look at different parameters. And the first parameter is from the patient's perspective. Is it effective as far as they're concerned? Is it satisfying as far as they're concerned? And is it convenient as far as they're concerned? Second thing, of the exact same questions to some degree for the provider, meaning is it effective? Is it efficient, which may be more important than for the provider than satisfying? But if it's efficient, it's probably going to be more satisfying. And is it cost effective? Because there are certain costs associated with being able to set up telemedicine communication in terms of our IT situations. But because EMR, electronic medical records, are such an integral part of our systems now, again, we had more of the telecommunications pieces already in place, so there was not a huge add-on in terms of cost to start to expand the utilization with telemedicine. And then the third person to keep happy is the insurer. From the insurer's point of view, is it effective and is it cost efficient? And as case managers, you guys are sort of in between all this. You're part-time in the insurer, you're part-time a provider, and you're part-time essentially the patient or the patient's advocate in all of this. So this slide's a little bit busy, but it's looking at studies that were done to specifically look at those different aspects of does it work. So from terms of effectiveness, there was a review of studies done between 1999 and 2019 that showed that in general, it had the potential to provide effective and accurate care. As far as being satisfying to the patient, study done in Norway showed 99% satisfaction rate that were either satisfied or very satisfied, and 86% of patients who had a telemedicine visit requested that their next visit be telehealth. Study in Pennsylvania, 2019, satisfaction rates that were similar between patients who had in-person versus telemedicine visits, and only 8% specifically requested a change for their follow-up from being telemedicine to being in person. In terms of cost efficiencies, several different studies showing the cost savings. The biggest cost savings typically is for the patient in terms of travel and time expenses, coming to, waiting for, having a visit, traveling back home. But the study also looked at the cost efficiencies or cost parameters for software maintenance, support salaries for support staff. And that part of it was also dependent on reimbursement policy. So obviously, if there's no reimbursement, then it is not cost effective for the providers to provide care this way. But if there is reasonable reimbursement, then it is cost effective as well. And then in addition to the specifics of cost effectiveness, additional studies that showed increased patient convenience, increased access to care, especially for more rural patients, and societal cost savings, which means cost savings such as gasoline utilization, theoretically effect on environment from that gasoline utilization for driving to and from visits, which you might think isn't that big a deal, but when you start to think of this in terms of hundreds of millions of visits, then obviously it does become a much bigger factor for those additional benefits. So what are the limitations? So the first obvious side of limitations is the technical aspect. For some people, technology and using an iPhone is a black box. There is definitely some level of age factor in this. It's not uncommon to see somebody take their phone and hand it to their 8-year-old kid to say, how do I get this FaceTime thing to work? So that's definitely a factor. And there is an age factor with that. The other aspect is just technical difficulties. Even when everything's set up, even with both parties understand what they're doing, we have a signal that gets dropped, or we find that the phone type doesn't match our phone type, or they didn't receive their instructions for how to log in, and we're not able to connect, or we're able to connect but not have a ongoing communication that is not stuttering or freezing or dropping. And the part of that are system problems, Wi-Fi connections, bandwidth, and there's another cost with this. We did have to increase some of our bandwidth system that we utilized for our network connections through the office. So those are the main technical limitations. What can we do to limit those limitations? First is that we set up a phone contact with the patient ahead of time to discuss the option of doing a telehealth visit. And part of that, we get to see what their sense of involvement with that is. There are patients who aren't afraid to say, I don't know how I would do that, and others that are anxious to do it. We then discuss what the options are. Typically, if somebody has an iPhone, we use FaceTime. And if they don't have an iPhone, we use GoToMeeting, which is a little bit more of a hassle factor for setting it up for the patient. But if they don't have an iPhone, it's fairly easy. We then send them the instructions to confirm with them that we're going to do a telehealth visit and what the instructions are for the communication. Then the day of the visit, we do a pre-screening done by one of our MAs. So they're doing the normal medical assistant work, meaning getting an update from the patient, updating their medications, updating their pharmacy, all the things they would normally do when they came to an in-office visit. And then this part of it is done by phone. The MA is then confirming with the patient how they're going to communicate with us, what they need to do, what they need to ask for or wait for us to set up the telehealth visit. For GoTo, where it's done through a computer, on our end, sometimes the MAs will actually set up the computer for me ahead of time. So I'm not trying to get there and find the patient and spend 5 or 10 or 12 minutes making that work. I basically walk into a room just like I would for a regular visit. And instead of Mrs. Jones sitting there, I've got Mrs. Jones on the computer waiting to talk to me. And one option in this would be trainers, people who we don't do this yet, but if we expand this concept, we could certainly have specific trainers that are more computer savvy and know kind of how to walk somebody through this to train our patients how to do this easily, but also to work with our own staff to make sure they understand the ins and outs of it. So other aspect of the limitations is the physical aspect. Obviously, the one thing that you can't do through telemedicine is hands-on dealing with the patient. I can look at them, I can see certain things, but I can't physically lay my hands on them. And so part of the problem is the viewpoint. If I've got a larger screen and they have the ability to set their phone back a little bit, then I can see the whole patient more easily. And that way, when I'm asking them to look at their motion and they're moving their arm off the screen, I can't tell what they're doing. If they're able to set up the viewpoint properly, we can get more out of it. One little anecdote, one of my friends who's a family practitioner was first working with their patients on telemedicine. The MA came on, let the patient know what they were going to do, and said, oh, by the way, make sure you're wearing something that's appropriate so it's easy for the provider to see the body part that you're going to be asking about. And this was a new patient. The physician had never met them before. Physician went on, clicked on the computer, the image came up, and there was the patient standing, completely buck naked, top to bottom, because they wanted to make sure that the doctor could see everything. Made them a little uncomfortable. Anyway, hopefully there's a giggle, but since I can't hear anybody, I won't know. So the examination, I think that how well you exam depends on what the body part is. If I have somebody that's a new patient with a shoulder injury, you can tell a lot in terms of the exam by walking them through different things, whereas to do a knee exam, especially looking at stability, that's not something that's easy to do through telehealth. Part of it's the patient's willingness to participate and their ability to participate in the exam themselves. And then there's the language barrier, which is always an issue, even when the patient is in the office. But when you add telemedicine, it becomes another factor that just kind of gets in the way more than it might otherwise. With that, because the patient's frequently at home, what I found is there's more often a family member present, and that's actually helped with that communication, because now you don't have to have a family member drive, take off time. They can just come on over and be there and help out. And then the difference between an initial examination and a follow-up. It's one thing to do a follow-up and say, hey, how you doing? And show me the shoulder motion, et cetera, versus an initial exam where I'm trying to do a diagnosis is a little bit more limited by telehealth than it would be for a follow-up exam. So what are our solutions? One is innovation, trying to come up with different ways of doing a better job. This somewhat grainy picture you see here is a project that's being currently worked on at Mass General, where they're using digital imagery. And in this case, what they're doing is they have a computer program to overlay a goniometer, which is an angle measuring device, on a patient in order to be able to accurately assess knee range of motion. And you can do the same thing for the shoulder and other things. And they're working on a variety of other technical innovations to make the physical exam done but through telemedicine more complete and more accurate. So I think we're going to see more of that, coming down the road as we go along. Patient participation, I mentioned. One is getting them to be able to set the camera or have a family member hold the camera for them in a place that gives us a good viewpoint where we can see what we need to see. And then you can have a patient participate. I can't poke on somebody and say, well, are you tender here or there? But I can show them where to poke and tell me, well, when you poke there, is it different than this side? And how about right on the very top? And how about at the base of your neck on that right-hand side? So I can get the patient to participate, to give me information that I wouldn't otherwise get unless I was standing in front of them. And then strength. You can do some basic strength testing with someone. You can have them put their arm out and give resistance and push out to the side and compares it to their opposite side. And they can give you a very good assessment of, wow, that's like half as strong as the other side, or whatever numbers there are. Or you could have a family member do the same thing for them and work with them. So if you get good family participation, patient participation, and buy-in from them, you can get through a fairly significant amount of a physical exam, at least orthopedically. When it comes to pulmonary exams or heart exams, yes, that's obviously going to be much more limited, but they already have technology now that they're providing to patients for direct communication with their Holter monitor, direct communication with their pacemaker to give them information and read it. And theoretically, they could give patients tools that they could do digital stethoscopes and other ways of working with patients who are, say, chronic cardiac patients or chronic pulmonary patients, where you could provide them with a tool set to work with you on doing remote exams. Going on to pros and cons. Cons, we talked about the technical difficulties, but those technical difficulties are, I believe, getting less because there's more availability. It's more commonplace. People are more used to working with this. The cons are the variability of patient willingness and patient capacity to do something electronically. And then there are, and will always be, some level of physical exam limitations, obviously, as well. The pros, obviously, time saving for the patient in terms of coming to the office, being at the office, waiting for a physician, and then getting back. And theoretically, especially for the injured worker, the ability to do some basic telehealth from work. We're seeing less time out of work to do their visit because they can do it on their 15-minute break. Obviously, they're saving the driving time and the waiting time as well. Clearly cost effective, very much so for the patient, and I think cost effective from the provider side as well. I think it's a very easy way to expedite updates to work status. We will sometimes do telephone updates from patients where we'll say, look, I'm going to see you in 4 weeks, but if things are doing well enough that you feel ready to change your level of activity at work, give me a call, we'll talk about it and update you. This is an even quick, more direct way of doing that rather than just the phone. You can say, it's really easy for you. We're going to do a telehealth visit. We're going to go through how you're doing, and we're going to update the work capacity appropriately without having to bring in another visit and take you out of work for a half a day to do that visit. Easier access to subspecialty care, especially in more remote areas, but even, I think, locally, because depending on how long the wait is to get into a subspecialist, if you have greater geographic capacity and not have to worry about how long the travel time is going to be, we may have the ability to get patients to subspecialty care faster, especially if they've already had imaging done, they've already had some preliminary evaluation done either by an OCMED center or by another physician. Then we can potentially get people to subspecialists in a faster, more efficient way. In terms of health exposure, obviously that's where this all started, at least this round of telemedicine. But it's not just for COVID. Think about how many people get exposed when they come to a doctor's office to somebody with a cold or somebody with the flu or other contagious diseases. And if they're doing a telemedicine visit, they're not having those exposures. And so there's a health benefit for limiting visits that can be efficiently done through telemedicine rather than a visit where you're sitting in a waiting room. I don't know this yet, but I'm willing to bet that there's going to be a lower no-show rate. If you think about how many no-shows are due to car troubles, which are the most common reason given for a no-show, that's one. Number two is reminding people. You get a phone call from somebody say, oh, it's time for your visit. Obviously, very often they're going to be like, oh, yeah, okay, let's do that. So my guess is that we're going to see a lower no-show rate, which especially for work comp is a huge thing because then you're getting the updated work comp form. We're moving forward with treatment changes. You're not just sort of have that waiting time of nothing happening and that sort of void of, oh, we're waiting for another appointment because they missed their appointment. And they can do it theoretically from a vacation just as easily, so you don't have then those other blanks in treatment timing frame. So what are the successful or things that we can do to make this more likely to be successful? And one, I think, is pre-prepping the visit, as I talked about a little bit before. One is when the appointment's made, making sure that they're on board with this and they're sort of invested in this and confirming their technical capacity and what they have as a phone or computer. Two, just like we do automated phone reminders, usually 48 hours before an office visit, is 2 days ahead of time, we call the patient, we confirm that they're going to do this, we confirm what technology is going to be used, we can confirm what number is being called, and we can confirm if there's a call in by them or a computer being used by them, what the sign-in process is going to be. Third step is immediately before the actual visit, the MA visit, again, revisiting all of these things and setting up the actual visit. And one thing that could be a possibility is involving other people in the process of making sure this is safe. You know, rather than case managers coming into the office visit to hear what's going on and see what's going on, case managers could theoretically also be people who could help out with this to sort of say, okay, Mrs. Jones, you know, you got your telehealth visit tomorrow. You know how you're doing it? Yeah, you got an iPhone, right? Okay, well, I've done that with you already, so you know how to do it, so you're ready for your visit. And then again, less drop-offs with that. What are some of the options to maybe expand the concept? One is what we're just talking about, or I was just talking about, which is using case managers as one of the coordinators in this system, both to encourage it for when it's appropriate, but also helping on the technical aspects. Another option might be including the physical therapist. The physical therapists very often see our patients way more frequently than we do. They certainly hear from their patients a much broader amount of subjective information, both, you know, health related and unhealth related, but again, they get more inside information sometimes. And theoretically, if you have especially say a remote patient, somebody's up in Berlin, they're receiving their therapy in Berlin, but they're coming down to see us in Manchester, if we set up the visit at a therapy time with their therapist, we could get the feedback from the therapist directly with the patient listening to the conversation. The therapist can help participate in demonstrating the range of motion, demonstrating where the strength is, demonstrating what concerns they have with what they're doing. They can physically demonstrate what they're doing with the patient to say, we've been trying to do this and it's not working. What do you think? So I think physical therapists could be a huge asset and expansion of telehealth information. Because as it is, we get the physical therapy notes, hopefully in time for the visit, but not always. But having that direct communication always is much more informative. Expanding the access to subspecialists. Again, we talked about this earlier, more direct access, more rapid access, because you have a greater geographic spread and you don't have to worry about, gee, how far away from where we are is a subspecialist and how hard is it to get in to see them. And then the option, which is actually an older system, when telehealth was earlier in its infancy, where people didn't have their own access to it, they would sometimes set up a center near the patient's home or nearer to the patient's home where somebody could come in, there was a video set up, and they could do a telehealth remote visit. We could potentially expand that to say, okay, we're going to have centers at different places around the state. Maybe it's in conjunction with a physical therapy place. Maybe it's in conjunction with the OCMED's facility, where you have the ability to communicate with the providers there, but they also have other access there in terms of a video that's set up with additional technologies to enhance the physical exam. They also have perhaps x-ray capability, lab capability, so that you could have the ability to do an initial examination, say, yep, these are the x-rays we want for this. They do the x-rays. You can then look at the x-rays all remotely rather than multiple separate visits trying to do it, one step at a time. What's going to need to happen to make some of these possible? One is we need the continued participation of the insurance companies. Again, they're currently mandated by the federal and state governments to reimburse for telehealth visits. And we're going to need the help from the federal government and local government bodies to continue to keep the HIPAA policies reasonable enough that we can do this without having systems that are so onerous to use that we can't use them, but obviously also having things in place to keep it as private as possible. Currently, both of these systems are going to expire. Both the mandate for paying for telehealth visit is going to expire, and the HIPAA policies are going to eventually expire. And I don't know, I haven't heard kind of whether there's been a lot of discussion, not just in terms of expanding it for now, but can we look at this as something that we want to keep using in the future? So what are the future things we might think about? Well, there may be future pandemics. This is the first one that we've been through in the modern era. Hopefully we've learned a lot about it. I'm sure we're going to be examining what we did and didn't do for many different aspects of it. But unfortunately, this is probably not the last time this is ever going to happen. So having systems set up for future problems would be a good idea. Maybe we'll have a paradigm shift that, you know what, going to work when you're sick maybe isn't a good idea. And maybe going to a doctor's office when you're very sick and contagious isn't a good idea. And why can't we expand telehealth to keep contagious people more centered in their own environment and less likely to spread anything, not just deadly flus, but quote, normal flu, which can be deadly as well. Because if you look at time lost from work by the quote, regular flu, I'm sure it's in the billions of dollars. And so if we can stop the spread when at each time, especially in the winter months from October through April, there would be a huge impact on the financial side, much less just the health side. Will it change because we're doing this now? Will this change our patterns in the future? Again, I think it's how we perceive it. First of all, the patients, if they're happy with it or not. Second of all, the providers, are they comfortable with it? I can say the more we've done it, the better we're getting at it and the more comfortable I am with it. Are the employers happy with it? Are the case managers happy with it? Are the insurers happy with it? If everybody's on board, I think that there's a very good chance that the pressure will be there on the politics side to help keep it in place going forward. I think it's one of these things that the more we work with it, the better we'll find that it is, that the more things we'll see we can do with it, and the more it will become kind of part of the norm. One of those arrows in our quiver that we get to use for certain situations to save time, be more efficient, keep the patients, from having to take time off from work to do it, et cetera. References, feel free to go through them. And American Academy just had another one that came out about the innovations at Mass General. It's an online one. I haven't had a chance to review it yet, but if you're interested in what they're doing or what they're trying to do, just go through, it's the Journal of Bone and Joint Surgery that's published by the American Academy of Orthopedic Surgeons. And I came up with some questions, but I think that Karen might have already put questions out there for people to answer as part of the CME requirements. So they're there if you guys need to use them. Otherwise, open for questions.
Thank you, Dr. Successill. I don't have any questions yet. If there's anyone out there who has any questions, now's the time to type them in the Q&A box, and we can have Dr. Successill answer those for us. A great talk, and I'm glad that you covered the issue of reimbursement for these types of visits. I know that they relaxed the billing processes, and Medicare allowed billing for telehealth medicine back when the pandemic started, and it's good to hear that, or hopefully they will continue to do that so that we can continue to expand this service. I know that I've been in the hospital, I've seen it used even before the pandemic hit, because I work in a smaller community hospital. So we use telehealth. We don't have on-staff neurology at the hospital, so we use neurologists by telemedicine. And I've also been on the consumer end, having had some health encounters this year and being able to have visits from my home. So I know that it really makes a difference for even those of us who are as young as me, never mind the older population. Let's see, we have one question. A question: how do medically, socially complex patients interact with the case management service or case managers in your office? Are they able to do that by telehealth?
So, I mean, I'm not sure I'm answering the right question, but links to it. So with inpatient visits, live visits, typically our case managers come in the room with the patient, unless the patient is requesting not to have the case manager physically present, in which case we meet with the case manager after the appointment. Obviously, there's a huge advantage, I think, to having the case manager face-to-face with the patient as well as with me when we're working to have that dialogue back and forth. So that's currently what we do for live patients. For telemedicine, we have not really been setting up like a three-way conference for it. That's something I would like to see happen, because what's happening is I'm having the visit with the patient, and either myself or one of our in-house work comp coordinators is then communicating with the case manager. So it's a two-step process rather than a combined process the way that it would be if the patient was coming for a live visit.
Okay.
But my understanding is we could certainly do that. It's, again, a little bit more technically complex, but I think we already have the capacity to do that.
And I think that probably applies most often to your workers' comp population, where there is a case manager who's very involved. And I sort of had a question about that as well. Knowing, and I'm not a workers' comp case manager by any stretch, but I understand that among the workers' comp patients, there can be a lot of malingering. Are you able to determine if a patient is being fully honest with you as far with your examination? Are there tips and techniques that you've learned to know whether somebody is holding back or not being as truthful as they normally would, or what your in-person examination would reveal?
So the answer is not as well as in person.
Yeah.
In other words, so the number of patients that are what I would consider truly working the system is actually pretty small. The number of patients who sort of symptom exaggerate is a slightly larger group, not huge, but enough. But unfortunately, those two groups of patients seem to take a much larger amount of everybody's time than the patients who are straightforward, honest, etc. There certainly are certain exam techniques to sort of get a sense of whether somebody's sort of, say, for range of motion, you know, they can get up here, but when we ask them to move their arm, they're barely, you know, getting up to here, etc. And watching them in the environment of an exam room where they're moving from a chair to a table and doing things with their arm, etc. Sometimes you have an opportunity to kind of pick some things up. There are some ways you could do it, having somebody repeat something at different stages in the exam through telehealth. If somebody's sort of not quite making a full effort, you'll tend to see a greater variation in what they do. But it's not the same as hands-on. You know, when you're hands-on and you touch someone in a certain way and their knees buckle and they just grimace in horrible pain and you're barely touching them, you know that we've got either a psychological component or a neurogenic component. But yeah, there is more limitation in that. And I think when you look at what's appropriate for a telehealth visit, what's less appropriate, the difficult patient, whether it's difficult because I'm having trouble figuring out the diagnosis or difficult because they're not really cooperating with the process, that's a patient who's going to be better off in a face-to-face visit.
Good. Thank you. I have another question. How do you address braces, x-rays, and imaging with a telehealth appointment?
Right. So great question. Right now, typically, some of the patients have already had imaging. So either they went to an ER with their original injury or they went to an OCMED center with their original injury and they already have some level of imaging done. And so if we have that, we don't get that from the patient. We get that usually directly from the facility that first saw them. So we have access to that almost always either directly or indirectly. Bracing is much tougher. Obviously, for bracing, you have to be, unless it's a very simple brace, there's a huge advantage to a brace person or orthotist putting it on the patient, seeing if it fits right, showing them how to adjust it, etc. But if I have somebody, say, through a telehealth visit and they say, you know what, I really think that with what you're doing on those uneven surfaces, you should be in a temporary anterior closure hinged brace, then what happens is I'll put an order in and the patient can come in at their convenience at any time that the office is open to be fitted and get that brace. So yes, they're traveling again, or they're traveling in place of the visit that they would have had, but they can do it at any time, so it's easier to fit in at the end of a day or before work so that they're less likely to miss work time from it.
Very good. Are there any other questions out there? Now is your chance. While we wait and see if anybody's going to add any questions, I'd like to thank you, Dr. Sarkisian, for presenting this to us. It's been very informative. I think that probably many or most of the people on the call have some experience with telemedicine. It's good to know how it's used in different venues that we work in. And I'd also like to thank New Hampshire Orthopedic Center for sponsoring this talk for us. I don't see any other questions.
Thank you very much.
Thank you. I don't see any other questions right now. I do want to remind all of our participants that you will get an email at the close of this program with your evaluation. You need to fill out the evaluation and return it by email, and your CE certificate will be sent to you. If for any reason you don't get that, you can either email Maureen at the office or you can give a call to the office and she will get it out to you. But thank you all for joining us tonight. We look forward to having you join us for our future programs. They are all listed on our website, cmsa.org. And please be safe and be healthy. Take care.
Thank you all. Have a great evening.